All right, looks like we're live. Welcome everybody to the American Head and Neck Society Virtual Education Series. We're excited for this instructional course this evening on the management of salivary malignancies. This is a case-based panel discussion. You can see our learning objectives here at the bottom of the screen. My name's David Cognetti. I'm at Thomas Jefferson University in Philadelphia. I'm thrilled to be joined here by Cecilia Schmalbach at Temple University, Will Ryan at the University of California, San Francisco, and Kiran Kakarala at the University of Kansas. I'd also like to thank Danny Anepakidis, as well as Boyd Gillespie, who are the section leads for the salivary gland section, and we appreciate their support on this, as well as JJ, Christina, and all the support at the American Head and Neck Society to get us going here this evening. I've been asked on the behalf of Sherry Ann Nathan, Bob Ferris, and Eben Rosenthal to remind everybody that the 10th International Conference on Head and Neck Cancer, which was canceled last summer due to the COVID pandemic, has been rescheduled and is booked for July 2021 in Chicago. So hopefully that will be able to continue, and we all look forward to that. So without further ado, let's get started on the cases. So case number one is a 53-year-old non-smoking woman with lupus, and she's on chronic low-dose prednisone for her lupus, who presented with a 4-month history of a right-sided neck mass. On examination in your office, it's 1.5 centimeters. It's firm but mobile. It's in the upper neck, tail of the parotid transition there on examination, but it's inferior to the angle of the mandible. She arrives with this CT scan in hand. So Cecilia, if you don't mind talking me through your impression of the scan and what you would do as your next steps.
Sure. So at least from the cuts that I can see, it appears to be parotid in origin. Certainly when I'm looking at that tail of parotid region, especially in an older patient, she's young at 53, but in an older patient, I want to make sure I'm not actually missing a lymph node that's distinctly in the neck. After I've gone through the scan, I have a very low threshold and will actually do an ultrasound FNA of these masses. I find that information very helpful. Obviously, if there's an aggressive malignancy, it's going to change my management with respect to surgical resection and neck dissection. At the same time, it's not going to give us the grade that sometimes helps with the salivary gland disease, but it certainly helps me prepare the patient for the expected outcome with respect to the facial nerve, and I know we'll be talking about that later on. The last reason that I will often do an FNA is that in my practice, I have a fair amount of cutaneous cancer patients, so oftentimes it's actually metastatic disease, and that will absolutely change my management. So I find that preoperative workup very helpful.
Great. And so you mentioned ultrasound FNA. Do you perform that right in your office, or would you do non-sonographic guidance in your office? And
so my preference is always sonographic guidance when possible. I have a wonderful rapport with our interventional radiologists and our endocrinologists. They tend to feed me pretty well, and so in return, I feed them, and obviously that's institutionally based.
Okay. Will or Kiran?
I do my own ultrasounds in clinic. I don't do FNAs myself. Actually, at UCSF, all of our cytopathologists are trained in ultrasound, and their clinic is just a couple floors down from us, and they have a walk-in policy, so we can have patients sent down the day of for that appointment. So it's super convenient. Sometimes I have a cytopathologist come up if the lesion is questionable as to where the needle needs to go, and sometimes they call up for that information. So, yeah, I mean, I think the other thing about FNA too is that sometimes these lesions are something that can be observed. It's a reactive lymph node. If it's a certain benign tumors, spindle cell lesion, for instance. So
Okay.
FNA is really pivotal with neck masses and with parotid masses, especially.
Karen, how about you?
Yeah, we actually, it's kind of nice. We have the cytopathologist has the ability to come to our clinic, and they actually bring a microscope with them, so they can sometimes give us a read right there, with the caveat, obviously, that they always give a caveat that they're going to overread it. But it's kind of nice for the patient sometimes. If we have an obvious diagnosis, we can have a discussion right there that time. But I agree with Cecilia. I think the ultrasound is great. If there's a question of where the needle is going, then I have interventional radiology do it.
Sounds like we're all spoiled by our cytopathologist. Ours at Jefferson, they leave a microscope. They have their setup in our office, and they just walk over. And a few years ago, they bought a new new ultrasound, and they asked, could they leave it in our office? And sure, absolutely, leave your new ultrasound in our office. So yeah, it's a good resource. All right, so just to the audience, if you have any comments or questions, feel free to engage in the chat directly with the panelists or even with each other. So as recommended, and final aspiration was performed. I don't recall this many years later if it was with ultrasound or not, but this is the final read. Atypical lymphocytes in a background of salivary tissue, question lymphoepithelial cyst. So based on this read, coupled with that CT scan, what are the next steps here? Cecilia?
Yeah, so, obviously with the atypia, young age, and I apologize, I can't recall if she had a little bit of pain, I would have a low threshold for doing essentially an excisional biopsy, which in my mind, when you're talking about the parotid gland, is some form of a parotidectomy because it, ideally is facial nerve preservation. So that would be my, recommendation to her. I don't think that repeating the FNA would be of great value.
Yeah. Okay, very good. So on that recommendation, I want to put the scan up again. And so Will, if you agree that the next step is surgical removal for definitive pathology, can you comment on what surgical approach you would consider here?
I guess just given those findings, I would ask if the patient's HIV positive and if the rest of the parotid has a bunch of these lesions. Probably not.
Patient is not HIV positive.
Okay.
This is the this is the only lesion.
Yeah, I agree that in general, repeating finding laceration biopsies, especially the parotid, is not really worthwhile unless there's cell inadequacy. At which point that is a good thing to do. So I agree with doing a excisional biopsy of this. This is mostly in the neck and really in the parotid tail. So, there's a few choices. One could do a modified facelift incision and raise a flap all the way down to this level. That's a choice. It's my default incision for parotidectomies. However, with this, I think I would do an incision overlying it that could be incorporated into a modified Blair incision later if need be. And it would maybe be about 3 centimeters. I'm thinking that this is right about here, just at the upper part of the sternocleidomastoid muscle, and would do it under general anesthesia, would have facial nerve monitoring set up, and perform an inferior parotidectomy in sort of an extracapsular style initially, defining the sternocleidomastoid muscle, defining the posterior biliodigastric, preserving the great auricular nerve, and then probably finding the margin-mandibular nerve out distally, if it's even a part of this, to make sure that that's dissected free, and then resect the mass. Sometimes these take 20 minutes, just depending on the depth of the tumor and how sticky things are.
Yeah. So great, just for orientation for the audience, because like almost like oral board style, you get two cuts here, right? But
Yeah.
so on the
Right.
left side, you have the axial cut and you don't see mandible at all. That's because this mass is completely inferior to the body and the angle of the mandible. And on the coronal cut, you don't see mandible at all because it's completely posterior. So inferior and posterior to the mandible angle is a pretty safe spot to approach cervically and really ideal for that. So let's see. So that's the approach that was chosen. I forget the exact size, but it was probably about 2.5, 3 centimeters in a natural crease, upper neck overlying the sternocleidomastoid muscle, almost like approaching a submandibular gland. You come from inferiorly where there's no nerve. All of that was very easy to dissect. And coming over the top, some dense fibrosis and inflammation was encountered. So the nerve was identified and, distal to the mass and traced back like Will just described, but it was pretty heavily adherent to the mass and sort of surrounded by this inflammation to the point that it was somewhat concerned about how do you separate the two and preserve the nerve, and also bringing into question the diagnosis. So if you're facing this intraoperatively, Karen, what do you do in this situation?
I think it's a perfect example of where intraoperative frozen section can really help with your decision making. I think there's some good data to show that using it, I think, in every case is a good idea. I use it in every case, and I think oftentimes it doesn't change the management, but there are a number of times, and this would be one of them, where it can give you important information about, in this case, how to manage the nerve, but also about what extent of parotidectomy to do, whether to do an elective neck dissection, depending on what that frozen section shows. So in this case, I would definitely, in this case, I guess you don't have the choice of resecting the mass and sending it, so you could do a small incisional biopsy of a portion of the mass to send it to the pathologist and get a sense as to what you're dealing with before making a decision about peeling it off the nerve versus sacrificing the nerve. In general, I think in a functioning nerve, regardless of what the frozen section shows, though, you would make every effort to preserve the nerve, even if that frozen section told you it was a cancer.
So on that note, would you be willing to sacrifice a nerve? And does it matter which branch of the nerve it is in terms, based on a frozen section?
Sure, I think it obviously some of these branches are much more important than others. Marge arguably is one of those that you could get rid of compared to the eye branches, zygomatic branch for SMILE. Buccal branches, I am pretty liberal with sacrificing if needed. That decision is a little bit easier, but yeah, there is some morbidity to sacrificing this nerve, and if the patient came in with function preoperatively, it's not a small decision, and that's I think frozen section can give you some extra information, and I would be pretty reticent to sacrifice the nerve in this case unless the frozen section gave me some really actionable information. And again, if it was working preoperatively, my practice would be to peel this off if I could, if I wasn't leaving gross disease behind.
Okay. So what we did was proceeded with, as you described, an intraoperative frozen section that did require an incision into the mass, if you will. And the frozen section result was epithelial components without evidence of malignancy. So based on that, effort was made to preserve the nerve and carefully peel it away and dissect it away. And so the nerve was preserved with some careful dissection. The final pathology came back low-grade mucoepidermal carcinoma, sclerosing variant, no perineural or lymphovascular invasion, and the margins were difficult to define because we peeled it directly off of the nerve. We had the incisional biopsy, if you will, and so you can't define a good, adequate, clear margin. Not surprisingly, she woke up with weakness of the marginal mandibular nerve due to the amount of manipulation. So all that being said, the question is, what do you do? What do you do next? So we have a low-grade mucoepidermal carcinoma with a tight surgical margin. The surgery was essentially extracapsular dissection, a excisional biopsy. Do you proceed with observation? Do you return to the operating room for further resection? Or do you proceed with radiation? And so to remind, I believe this woman was 54 years old and a history of lupus. So this is it for the audience to respond. You can see that the audience question has popped up. So plug in your answer. All right, we can probably close.
While we're waiting, one of the Q&As came up asking what about a core biopsy instead of an FNA going back to before surgery. I think core biopsies can give a little bit more information, but the problem is they're traumatic. They have a theoretical increased chance of seeding, and then they can injure a nerve or cause a hematoma. So those are reasons against that.
Yeah, and pretty small.
You guys feel about cores?
I agree. I mean, I think what I find most helpful is just to talk to the pathologist and ask them if any additional cytology, via a core would be helpful. Sometimes it can be if they're worried about metastatic disease from elsewhere and they need immunohistochemical staining, but that is really the exception. The only other thing I can think of is lymphoma, if you're really putting that in your differential. Again, it seems that at most institutions, the pathologist is always going to want more tissue and the hem-onc doc as well. But it's a great question to ask. And again, I would just encourage that you dialogue with your pathologist before ordering it.
I mean, this patient could have had a malt lymphoma being lupus, right?
So I don't know if that audience response worked. Did we see results?
It did. I'll share them right now.
Yeah.
Okay. All right, look at this. We were able to hit at least some controversy here. So we have observation winning out at 55%, radiation number 2, and return to the operating room for further resection. So Cecilia, do you want to comment on your thoughts to how you would manage this and the audience response?
Yeah, sure. So I absolutely, I would have managed it with observation. But having said that, I would have absolutely done it in the context of presenting her at a multidisciplinary tumor board, because the textbook answer is if you've left disease behind, that you get radiation. But the complexity of her situation is she's young, she's 53, and she has lupus. And that's where I'm really going to value the input from my radiation oncologist. I do think that you owe it to the patient to disclose that, the tumor's peeled off of the nerve. Usually we preserve working nerves, but there, is a very good chance that there are malignant cells left behind. And when I say observation, I would want to do it closely with radiographic imaging, preferably an MRI. Lastly, if this was a patient that I did not think was reliable and going to diligently follow up, that's someone that I may consider instead radiation if they would actually go through the full treatment, or just going back for resection. So it's very much individualized.
So great. And to clarify, based on your comment and Peter Scholl's comment in the chat here, there was no gross disease. This was a complete gross dissection. It was just the nerve had to be meticulously separated.
Did the nerve look basically normal when you left it?
What's that?
Did the nerve look normal when you left it? Like a dissected normal?
Yes. And there was no perineural, et cetera. For those, and I don't know what anybody here would have voted, but for those who return to the operating room for this, I guess the question is, what operation are you doing? Because I guess the only thing you're doing is going back in and taking out the nerve. And so I guess another open question is, does the fact that her nerve's not working post-operatively influence that? And so is there a big harm to go back in and take out the nerve? Will?
Well, nerves that are intact usually return to function. So, I mean, almost always. So I think we could consider it a nerve that will one day function within, 2 weeks to 3 months. I think one of the issues here that is a little different than some parotidectomies is that we haven't done much of a parotidectomy. I don't think, right? The rest of the facial nerve was not dissected. This is just a parotid tail. Is that correct, Dave?
Correct.
So it means in low-grade mucoepidermoid carcinoma, the most likely recurrence would be a local recurrence. And if we made a little 3-centimeter incision, or just had an incision in this area away from the rest of the nerve, then a local recurrence could be caught. These are indolent cancers, and it could be re-resected and then potentially radiated at that time. So it makes me not as interested in radiating, although I think, Cecilia, you're right, the patient deserves to know all the issues at hand, and a tumor board should be a part of this. And ultimately, the patient could make the decision in this case.
Yeah. So in interest of time, I'll give you the follow-up. So yes, we had multidisciplinary discussion. We discussed all sorts of things like her young age, her lupus diagnosis for radiation. We discussed that if it were to recur, being low grade and sclerosing variant is a indolent variant, that the recurrence would be local and probably salvageable, with the worst case scenario that you're resecting that nerve at that time. So to go in and take out the nerve at this time to prevent taking out the nerve later, it didn't completely add up. And yes, to Cecilia's point, a very reliable patient. Radiation was discussed. Patient waited out and opted for observation and reliably followed up. And my next slide here is just showing an MRI at 5 years later. She's now closer to 10 years out, just showing her intact parotid and no evidence of recurrent disease. And her nerve did recover function as Will predicted. It took a few months, but it came back. All right.
Nice.
What we got here, so Will, you mentioned approaches earlier.
Yeah.
One question I have is, what if this tumor were higher in the gland? What would your approach be instead of this transcervical? So now you can see we're not below the mandible. You can see parotid parenchyma on all sides of this.
Mm-hmm. Yeah, this is something that I think I mentioned, that my default is a modified facelift incision, which usually retrotragal. If there's a preauricular or a pretragal crease, I will use that. And these facelift incisions, and most people probably on this Zoom call know, or go around the lobule and then back into the hairline this way. You can do a periauricular incision too. Some people practice that or espouse that. You need the exposure, I think, to some degree, at least preauricularly, to get to this. Because in this case, I would perform a more traditional facial nerve trunk dissection to resect this. It makes the story of it being on a nerve a little bit more, makes me more inclined to radiate in this situation, actually, if we were going to put all this into the same scenario.
Okay. In terms of the workup, Cecilia, is there anything, if you have like a T2 bright tumor like this, is there any situation where you don't favor a needle? Back when I was in medical school reading Meyer's first version of operative otolaryngology, I remember that chapter basically saying you don't need to needle biopsy parotid tumors, you need to get them out. They don't belong there. So,
you weigh the risk-benefit ratio, and in 2020, the risk of a needle biopsy is pretty low, but the information that it's going to give me is just really going to help me counsel the patient better and prepare me better for those tough intraoperative decisions when you do find it adherent to the nerve, et cetera. So I have a very low threshold and can't honestly remember the last time I went to the operating room without a needle biopsy. Now, if it's non-diagnostic, then you got to commit.
All right, very good. So as Will was describing, this is just showing you the rhytidectomy approach. So this is, I think this is that patient in that last scan months later. This is a different patient where I had a fresher 1-week image of you can hide an incision, you could extend it forward if you want and hide it up behind the ear, and you can get some really nice access when you want a little bit more top-down dissecting the branch. So case number 2, and I like the discussion in the chat. Keep it up, everybody. It seems like we're getting good discussion going. Case number 2 is a 76-year-old male who presents with a right-sided parotid mass. It's been slowly growing for 6 months. He does have some pain, and he has a history of cutaneous squamous cell carcinoma of the ipsilateral temporal region, which was treated with Mohs 18 months prior. So I'm sure that this is a scenario that we are all familiar with. So here we go here. Just looking, Karen, why don't you comment on the exam here and the MRI findings?
Yeah, so the clinical picture, you can see the obvious parotid mass. And so I'd want to know about his facial nerve function, and I'd want to examine the region where he had his primary resected, the primary skin cancer, and look for other primary skin cancers. And then looking at the MRI there, you see a lesion in the superficial parotid that seems like it has some extension down to the deep lobe. It's kind of wrapping around the back of the mandible and touching the masseter muscle, and looks like it might be pushing on the retromandibular vein. And so it looks like a fairly extensive lesion of the both superficial and deep lobe.
Very good. And yeah, this is anatomically an interesting spot that we'll talk about in a little bit. The needle biopsy is performed. It's positive for malignancy. It's not surprisingly shows squamous features with high-grade morphology. But perhaps surprisingly is the fact that it is P16 positive. So what does that mean to us, Cecilia?
Yeah, so it's a great question, and I think we have to first ask ourselves, do we think this is cutaneous in origin, or do we think that this is mucosal in origin? Obviously, if it's mucosal, it's a whole different panel. If it's cutaneous, though, I think the key point I would want our attendees to recognize is we do see P16 staining in cutaneous squamous cell carcinomas, but again, it's just a surrogate. And when they've done studies, actually it does not correlate. What it correlates with is not HPV. It correlates with poor differentiation. So in my mind, if this is going to be cutaneous squamous cell carcinoma metastatic to the parotid, which I believe it will be, it doesn't change my management.
Yeah, and so here's a good paper that references that P16 status in a cutaneous malignancy really does not have meaning, and certainly does not indicate HPV or even prognosticate. So in this study of 166 patients, 32% had immunostaining with P16, but when they did the in situ hybridization of HPV, none had HPV, and there was no correlation with outcome. So essentially a non-factor, as Cecilia just described in her management. All right, so now we have a PET scan. And Karen, any role for PET? Do you use PET for salivary or metastatic cutaneous?
Yeah, exactly. I don't use it routinely for salivary malignancies, but this is one example of where it can give some information. for high-grade lesions that might have a higher metastatic potential. I think there's some comparative studies that showed that PET-CT has some additional information over and above traditional cross-sectional imaging for looking for metastatic disease. So in a guy like this, it might give you some extra information as to what the status of his other regional nodes would be, as well as whether he might have metastatic disease, because that might change your discussion as to what the initial management might be. I think it's important to note that it's not the most routine or the most useful for parotid malignancy in general. It doesn't have the best ability to differentiate between benign and malignant, because some benign parotid things will light up on PET scan and some parotid cancers won't light up on the PET scans. But as long as I think you understand those limitations, we do use it not for every case, but for some of the more high grade or advanced stage cases, it can pick up some metastatic disease that might be otherwise missed.
Great. Yep. So for this gentleman's PET scan, there was no evidence of distant metastatic disease. There was equivocal activity in level 2 lymph node. So Will, what's the plan?
This gentleman needs surgery and post-operative radiation. So I would describe the operation to him and get him ready for that. He's otherwise pretty healthy.
He's otherwise pretty healthy.
And his facial nerve's intact, right?
His facial nerve is working completely, 1 out of 6, coming into your office.
So for the surgery, I would plan a total or near total parotidectomy. I would actually have a facial plastic surgeon ready, because given that deep extent and abutment of the masseter muscle and the ramus, I imagine some of the facial nerves will be either very close or possibly involved. I would plan a elective selective neck dissection. I do posterior 1B through 3 in this scenario. I know there's a variety of extents that are performed by various surgeons, as the data is not super strong either way. And would plan for a contour defect reconstruction. I do abdominal fat free grafts for this, but there are different choices. For benign disease, I do sternocleidomastoid advancement flaps, but for cancers, I use fat because I think it is more easy to distinguish during surveillance scans.
And you use abdominal fat even when radiation's anticipated?
I do. When we're doing a mastoidectomy, or the sternocleidomastoid muscle has to be removed, then usually at our institution we do an anterior lateral thigh free flap that's de-epithelialized. Or if there's skin that has to be removed, then I would do a free flap usually in this situation.
Any other thoughts from the other two for the audience? I included this picture to show this nice hanging mental area, just in case anybody noticed.
Yeah, you could do it.
But obviously, there's lots of options for reconstruction here. Cecilia, Will asked whether he's healthy, and we've already covered he's got no metastatic disease. Is there any role for cemiplimab?
Yeah, I mean, it's a great question, and we're still learning a bit about that. Certainly, this gentleman has one shot at cure in my mind, just with the location. And so if he's a surgical candidate, I would absolutely advocate for surgery and reserving systemic therapy. When we look at the FDA indications for the PD-1 inhibitors, both cemiplimab and more recently pembrolizumab, it really is end of the line. So either a patient that's not a surgical candidate or has already failed surgery and or radiation. And so I would not do that out of the gate unless he absolutely refused to undergo surgical treatment.
Okay. Very, very helpful. All right. So these are the intraoperative pictures. And what I'm showing you here on the left side of the screen is the entire parotid with tumor within it reflected back. By this point in the case, the superior division has already been sacrificed. It was grossly encased. And what I'm trying to demonstrate here is the auriculotemporal nerve as it comes out from around the mandible I pointed out pain earlier and sort of that projection on the PET CT. This is after complete tumor removal with the lower division, which was uninvolved, intact. And just a comment on the auriculotemporal nerve. This is a paper we put out a little earlier this year. I get a shout out for my chief resident, Brian Swenside, who's going into head and neck, will be at Ohio State next year for fellowship, for putting this together. But we looked back at our parotidectomies for cancer and looked at all the local recurrences and found that a lot of the recurrences actually occurred along the course of the auriculotemporal nerve. And there was correlation if there was facial nerve involvement, upper branches of the facial nerve, pain and other symptoms that could correlate with the auriculotemporal nerve. And anatomically, there's connections between the two nerves. So it was something to keep an eye on for when you're doing these more advanced cancers or those with high suspicion of paraneural involvement. So he got, as summarized here, the submental flap, the upper division sacrifice, a platinum weight, and this is him in the immediate post-op. So let's go back to our audience. So we have some chat too.
Yeah, David, I was just going to mention there was a question about whether the submental flap is oncologically safe in this situation. And I don't think there's papers on that, but there are papers on using submental flap for oral cavity cancer. And I think that's been shown in the clinically and zero neck to be oncologically sound if you do 1B dissection. And you can remove 1B and 1A nodes even with that submental flap and still transfer it. And so I think the answer is yes, it's still a good option. And actually it's one of my go-to options. Submental and supraclavicular have really replaced free tissue transfer for me, at least.
Yeah, and so I would say in this scenario, it's not at the sacrifice of taking out the facial nodes, right? So you have to take out those facial nodes. You just have to be very meticulous and careful around the facial vessels. And another question here about deepithelializing and buried. Yeah, this is a buried flap. And if you want to start practicing submental flaps, this is a great way to do it, because your risk is you have a devitalized submental flap, which is essentially a dermal fat graft and buried in your parotid bed, and it's probably going to survive anyway, which is different than putting it into the oral cavity where your prevention of fistula relies on it. So we have the poll open, so you don't have to vote in the chat unless you want to tell everybody what you prefer. But the questions are, what's your recommended adjuvant therapy? So the pathology is here. There were 3 out of 31 lymph nodes. There was some extranodal extension. All nerve margins were negative.
Okay, it's leveling off. I'll post it in just a second. Okay, there we go. Here it comes.
All right. Okay, look, we've done well, team, hitting the controversial points. We have a 50-50 split of, well, not quite 50-50. We have somebody observing, but we have chemoradiation versus radiation here. So Cecilia, do you want to comment on this?
Yeah, at my institution, it would be adjuvant radiation due to the ENE multiple nodes and PNI. Right now, as far as adding chemotherapy, we've not found that it has been as helpful compared to our counterparts in mucosal disease. So there's the TROG trial that's out there, and it did not show a benefit with the addition of systemic therapy to adjuvant radiation, and that's why I would just do adjuvant radiation alone.
Yeah, so let me see here. We could probably close this, move on here. This is the TROG trial that Cecilia is referring to. This is randomized controlled data, 323 patients. This is radiation versus radiation plus carboplatinum. And so I guess a question, does that really approved, well, I should go to the results of this, which is treatment was well tolerated, but there was no, you can tell by the Kaplan-Meier curves, no impact on survival to add carboplatin to radiation. As you can see in the title there, high-risk cutaneous squamous cell carcinoma of the head and neck. So this isn't salivary, this is exactly this patient. There was no worsening of toxicity with carbo, so was the agent strong enough, if you will, to cause toxicity or effect? I don't know. I would think in practice, this patient may get chemotherapy in a lot of centers, and maybe the other people can weigh in.
Yeah, we just discussed a patient in tumor board this morning, very similar scenario. And actually the medical oncologist brought up this TROG trial and then said we should still give chemo. So I think it's a hard choice because this guy was a young guy, healthy guy. You want to throw everything at them to try to get cure, but it's kind of flying in the face of the data we have. So until we get better data, I think we should go with what we have.
So before the chat,
I mean, cisplatin wasn't used here, right? So
no, it's carbo.
right. So that's an important thing to remember. And the problem with cisplatin, and one of the reasons I don't think it was used for this trial, is that it has more toxicity, and particularly in patients that are probably in their late 70s and 80s, like many of the skin cancer patients we see. So I think we need to remember that about chemotherapy. I mean, even for mucosal squamous cell carcinoma, where it's been shown to have, where cisplatin's been shown to have benefit, 20 years ago, there's still those randomized controlled trials that showed its benefits, showed real adverse events occurring in a big percentage of those that had cisplatin. So each patient needs to be taken on case by case to make sure they can tolerate that type of chemotherapy.
Cecilia, there's comments in the chat here, including from our boss, Evan, asking about neoadjuvant immune therapy in borderline resectable and or even maybe in the adjuvant setting. Like, can you touch on this slide and the role here?
Sure, those are great questions. So I'll begin with just saying right now, we're excited that we have 2 PD-1 inhibitors that are FDA approved, again, for either locally advanced and or metastatic cutaneous squamous cell carcinoma, but again, end of the line, either failed surgery and radiation or aren't candidates. This initially was back in June with cemiplimab, and I think it's important for folks to know it was still a small trial. It was only 59 patients with almost 8 months of follow-up, so fairly short. And they were looking at the objective response rate. And although we're excited about this tool, and I think there's a lot more to learn, it's important to realize that just under 50% of patients that received it responded, but only 4% were complete responders. 44% were partial, and the duration was short. It was 6 months as far as that durable response in 61%. The follow-up more recently with pembrolizumab was a slightly larger, over 100 patients, but again, the numbers there mirrored it. So we still have quite a bit to learn. There are trials that are looking at potentially the neoadjuvant use that Evan had asked, and I think someone else had asked in the chat, it flashed by about adjuvant use of chemo, and then the PD-1 inhibitor. So that would only be given right now in the context of clinical trials. The last key point I think it's important to remember is that the mechanism, it suppresses T cells. And so right now, the biggest side effects are autoimmune, and it can be a wide range from pancreatitis to pneumonitis, a lot of GI problems, but it's currently broadly stated that it's contraindicated in transplant patients. What I really like to say is you have to recognize none of the FDA approved trials included our immunosuppressed patient populations. There are some small studies that report using it, some cohort studies, and they're trying to delve further. The problem is right out of the gate, there's a 50% fulminant rejection rate for your transplant patient. And so that's maybe not as big of a deal if it's a kidney, but if it's a heart or a lung, there's not a whole lot of backup. And so again, I think it's just a very candid conversation to be had with the patient. And we're going to learn a lot more with respect to the other applications, adjuvant and neoadjuvant.
Great, thank you. All right, so this is him, and through the wonders of telemedicine, I was able to capture this video of his facial nerve function. Now, remember, we preserved his lower division, which actually was quite functional and helped there. Let's see. This slide is courtesy Dr. John Yu, talking about facial nerve reconstruction and dividing the face into subunits to minimize synkinesis and to maximize function. And this is nice. If you look here, the upper face, the orbital division, would be approached with a cold weight, tarsal strip, and a cable graft. The mid face is a 5 to 7 transfer, and the lower division is an ANSA to 7 transfer. And this is from the paper. You can see nice function there. I was going to share a video of somebody who had a 5 to 7 transfer.
Smile. All right. How about clench your jaw?
You can see when you train them, when they clench their jaw, that's some really nice facial symmetry that's dynamic. So that's a relatively newer technique that is working well. So let's move on to case number 3. This is the last case. We might have to move through it a little bit quicker, but hopefully will be of interest. This is a 44-year-old woman who had discomfort and tenderness in her left parotid. She reports going on 10 years. She denies feeling any mass or even significant progression of her symptoms over that time frame. She had no trismus, no periprandial exacerbation, and she also had normal facial nerve function. Eventually, she got an MRI. If I recall her history, I think she had some denials from her insurance company initially, but eventually she got an MRI that showed a 1.6 by 2 centimeter mass in the deep lobe of that parotid. Non-specific characteristics, no cervical adenopathy. Needle biopsy did not survive processing, did not have significant cells to be able to make a diagnosis other than this is a salivary gland neoplasm, and she had a lot of pain with the needle biopsy. So I don't know if there would be, I should pause here. When you have a non-diagnostic needle biopsy, well, what would be your next steps in this situation? Kieran, you wanna comment?
Yeah, I mean, we talked about core before, but I think I'd be reticent to do that. So I think you just have to have a conversation with the patient about what you're suspecting. And in this case, I think moving forward with surgery would make sense to get a better diagnosis in intraop frozen section.
So when you're going for a surgery without a pathologic or cytologic diagnosis, how deeply do you prepare your patient, Will, for the possibility? So here you have non-specific mass. You have some concerning findings that she has discomfort. You have some reassuring findings that it's been 10 years, but maybe that's not reassuring for the type of stuff we see in the parotid. So what kind of conversation are you having with her?
What was the FNA? There wasn't enough cells to analyze it. Is that?
This is here.
Then I might
cells.
repeat the FNA.
Characterization.
Yeah, I might repeat the FNA if it's inadequate specimen.
She did not enjoy it, and she has no interest in that.
Okay. And I talk about risk to the facial nerve, obviously, and all the other risks, seroma and bleeding, infection, Fry's syndrome, great auricular nerve numbness. So without a definite diagnosis, I would explain that it could be cancer and something may need to be done about that. So, but
yeah,
we'll see where this goes.
Yeah, so all that happened, but not necessarily to the same level of depth that when you're holding a cancer diagnosis in hand, if you will. Yeah. So we take her to the operating room, find the facial nerve, no problem with the lateral approach, it stimulates normally, and tracing it out, or you can feel the mass, but tracing it out, things get stickier and stickier and stickier to the point that out near the pes, the inferior division is completely encased by just abnormal, nondescript inflammation. That is sampled and sent for frozen section, and that parenchyma had adenoid cystic carcinoma. So now you're in a situation where you have a 44-year-old woman. Sure, you talk to her about risk of facial nerve as you do for every parotid case, but you didn't really necessarily prepare her for full facial nerve sacrifice and/or all the stuff that we've talked about in previous cases with regards to having your reconstructive plan in place and team and consent, etc. So ideally, you're not in this situation. Unfortunately, I was. And my question for the audience is, what do you do now? So intra-op, you have a decision to make. Do you abort this procedure at this point? You leave mass, you leave the nerve, you wake her up, you describe the findings, and you proceed with definitive radiation. Do you do a gross tumor resection, kind of like we did in that first case? You preserve the nerve, you wake her up, you see if it works, you do no further surgery, and you proceed to radiation. Do you sort of go to the middle ground? You do that gross tumor resection so that you're not leaving any gross disease, but your plan is to have the conversation, prepare for reconstruction, get your plastic surgeon on board, get the patient comfortable, bring her back for a second procedure for definitive oncologic cleanup prior to adjuvant radiation? Or do you call whatever family members with her, get verbal consent to take the facial nerve there on the spot and do your complete oncologic procedure that day? There is no necessarily right or wrong answer. We'll see if we struck as much controversy as our previous questions.
Are you all using the Malign classification for salivary gland FNAs at your institutions?
Our cytopathologists typically report on that now.
We have just started doing.
It wouldn't have been back then. Yeah, this case is about 10 years old now.
I'm just seeing it in the chat room. So.
All right. So
Almost
are we
there.
filled up, JJ?
Yeah, one more second. There was a couple more answers coming in. Okay, now we seem to have leveled off. Here we go.
Drum roll, please. Look at this. Yeah. All right. So the most popular is do everything you can without bagging the nerve, peel it off, etc. And then we plan for facial nerve sacrifice after finding pathology on a separate day. Our panelists, do you agree with that? But I guess it's somewhat reassuring that the most popular pick was what he ended up doing. So that's the approach that was taken. The final pathology confirmed adenoid cystic carcinoma. It was both in the superficial and deep lobe, above and below the nerve, as we expected based on our findings. The biopsy sort of right along what was left of the nerve was positive for perineural invasion. We did sacrifice one buccal branch, which was completely in the middle of it. That was positive for perineural invasion. The pericarotid lymph nodes were negative, no major dissection there. And after waking her up, we did a distant metastatic workup that was negative as well. Ironically, after all that dissection, her nerve was completely intact. Like it'd almost be easier in this case for her to have a dense paresis to have the conversation you want to have, but her nerve's intact, so she's back in your office and you have to make a decision here. And it was tumor board discussion, radiation, all that, and she opted to return to the operating room for a facial nerve sacrifice. That was done about a week or two later. You can see here, mastoidectomy to clear the nerve. which was ultimately cleared. You can see the sural nerve cable graft, and there was residual cancer in the nerve, and there was residual cancer in the soft tissue, which was right around the nerve at the stylomastoid foramen, which is, I find, a very difficult area to clear if you're not taking the nerve. Beyond that, all the margins were ultimately negative. This is her reconstruction. You can see that this procedure was done through a rhytidectomy incision, as referenced by Will before. She ended up with dermal fat, and you can see all the other static stuff. So I think we have one more audience response. No, we don't. Good, because we don't have much time. So she got radiation without chemotherapy, and it was, you can see in the reconstructive pictures, what was remarkable about her, and probably a testament to her young age, she had really good recovery of function with her cable graft, to the point that 6 months after surgery, we removed the gold weight, and these are her pictures. Unfortunately, what we know about adenoid cystic is it's really difficult, and she ended up developing a distant metastases in her lung. About 18 months later, she's now 9 months out total. She has progressing lung metastases, but still no local regional recurrence. So in the few minutes we have left, because I saw one of the questions, how far would you chase nerves for adenoid cystic carcinoma? It's like we planted these people in the audience, because their questions just lead into our next slide. What happens when you can't clear the nerve? So this is a different woman. She's a little older. I think she's in her early 60s. You can see her MRI scan there, again, wrapping around the mandible. This is an intraoperative picture where it encased the upper division and was relatively abnormal right until just about the pes. So the sacrifice was immediately against the takeoff of the inferior division. And what I'm holding in this picture is that auriculotemporal nerve, which we identified, again, following its course around the mandible here. And in her, all of the margins were positive intraoperative. The main trunk takeoff, the auriculotemporal nerve, and every single upper division distal margin were positive. So we were left with, how far do you chase it? Karen, how far would you chase it in a situation like this?
Yeah, I mean, I think you chase it where it's reasonable. So I don't know if, did you do the mastoid in this case? I think we'd certainly drill out the mastoid and ask our neurotologist to chase it as far back as they could. And then all those distal branches as far as you could. I think there is some benefit to trying to get to those negative margins. Now, of course, if your closest margin is your closest margin, so it doesn't make sense to chase all these other margins and then leave some big Goomba somewhere that you can't resect. So I think you have to just use your judgment. But if it's possible to clear the margins, I think you do try.
Very good. Very good. So if it's possible, I guess, so let me show you her path report. So intraoperatively, we chased every single margin that we could, with the exception of the main trunk, and every single margin, re-resection and additional margin. So following, around the mandible as far as possible on the auriculotemporal, followed every distal branch until they weren't even branches anymore. They were all still positive. So at that point, I made the decision, don't bag the main trunk, leave the inferior division. It's grossly appearing fine, and we haven't cleared any of her microscopic disease. And that this is a case for radiation that she'll need. I think because of our time, we're going to skip the last panel discussion, which is basically asking some of the stuff we talked about. Do people favor modified Blair versus rhytidectomy incision? Just showing, I like this study where it shows that people before surgery, they're really worried that you're going to cut their nerve and ruin their face. But after surgery, because most people don't have that problem afterwards, people are much more worried about the contour defect you left them and the scar you left them. So there is some benefit for taking these approaches where you can hide your incisions and you can fill the defect. This is a young woman showing the kind of exposure you can get and fill it with, I think she had a cynic cell carcinoma, fill it with fat, and this is several years later, maintaining that function and appearance. This I just did earlier this week, a 5-centimeter pleo through a rhytidectomy incision. So in closing, the take-home points are FNA provides valuable information for surgical planning. We all advocate for it. The addition of chemotherapy has not been proven to be beneficial in the adjuvant setting for high-risk cutaneous or salivary carcinomas. We know that RTOG 1008 will hopefully answer that question for the salivary side. Cemiplimab is FDA approved for locally advanced and metastatic cutaneous squamous cell in patients who have failed or are not candidates for surgery and/or radiation, and reconstruction after parotidectomy, whether it's for the nerve or without the nerve, it should be considered really for all patients when feasible or reasonable. And the final slide I've been asked to share for the people who are not members, please consider membership. There are lots of benefits to that, and we've certainly appreciated you logging in tonight. I think we're a minute over. Have we covered all our questions in the chat, panelists? I don't know if you've been looking here. These last slides are just looking at the active trials that are going on in salivary malignancies. So I'll leave it on that slide. Thank you, everybody, for your time. Thank you again to the panelists. Really enjoyed working with you and learning from you this evening.
Thank you, Dave.
Thanks
Nice
for
job.
your
you.
time. Have a great night.
Bye, everybody.
Good night.